Today I'll be talking about the fungal pneumonias. Fungal pneumonias, usually we have a lot of fungi that we can come across in our day-to-day life. As a pulmonologist, I'm sure you must be seeing a lot of them. But the two major funguses I'll be talking about today, the molds, which is Aspergillus and Mucor. I have only 20 minutes to cover those two, so I'll see whatever. I want you to take at least few learning points and go back, hence I have not kept it very congested. So this is how I'll be talking. Now, pulmonary invasive fungal pneumonia. Usually what happens, Aspergillus is a ubiquitous fungus. It's present everywhere. It's present in the atmosphere, it's present in air, soil, anywhere there's construction, it's there. So what happens when this fungus is available in two forms? One is conidia, which is a hydrophobic molecule, and it has to undergo some type of stress, atmospheric pressure or temperature changes for it to start sporulating and form that spore that you see. Okay, so these are not always found in infectious state in the atmosphere. They have to undergo some kind of modulation or modification for it to become an infecting agent. Now, not everybody who gets exposed to these funguses actually becomes infected. They may actually dodge this fungus away if their immune system is well functional. So, okay, this seems to be not working, yeah? Okay. Shall we stop? I should continue. Okay, thank you. Thank you. That was nice. Okay. So, a person's innate immune system should be well functional for any fungus to, especially Aspergillus and both Mucor. The neutrophil part of your immune system should be very well functional, and they should be aptly good in numbers, and not only numbers, they should be aptly functional also. So when that happens, then only a person will be able to dodge this fungus away. Apart from that, if their T cell repertoire is not affected and well conserved, then also they will be able to dodge this fungus, if not at the initial level, to some extent. But neutrophil part is very important, especially for the Mucor. Develop these fungi infections, especially Aspergillus, but I want you to remember this. Anybody who has severe prolonged neutropenia are at higher risk. Anybody who has received higher glucocorticoids, they are at this. So this is how it looks. So now why I'm showing this picture to you now, we all are having one boom in a molecular diagnostic. We are using a lot of beta-3-D-glucan and galactomannans. These are nothing but glycopeptides which are present in the cell wall of the fungi. So you can see these yellowish, I don't know if this, yes. These yellowish particles, they actually, they are galactomannans, and then these orangish thing is actually beta-D-glucan. So these things, when they can be picked up by a molecular testing, you can do a test to pick them up, and that can help you again act as an aid. They are not diagnostic, but they can act as an aid. So galactomannan, when a person is not on any prophylaxis, galactomannan is actually something that you can use for prospective screening, and in such cases its sensitivity is better. But if somebody is on a fungal treatment, then you should not be using galactomannan. It will give you a bad result, and its positive predictive value is poor. It can be used in bowel fluid. It has sensitivity and specificity up to 90%, so it is actually a good test in such patients when done in a lower respiratory tract sample. But there are problems. There's nothing that is without a problem. The problems are the sensitivity of detecting galactomannan is decreased by administration of mold active agent, as I said. False positive results are a bigger trouble. They can be seen in patients who are on beta-lactam antibiotics, who are on, who have other fungal infections like fusariosis, histoplasmosis, etc., who have been having, taking these IVIGs or have GVHD or mucositis. So this can have a false positive result. Hence, it should be predicted when you have other evidence or a host which is correct. So that has to be kept in mind. Beta-D-glucan is another assay which is very easily available and has to be used. So its overall sensitivity and specificity to diagnose is around 70% and 90% specifically. But it can be, if you are using it in for screening only, it may have poorer sensitivity. So you should not use it as a screening test alone in a person where you are not having high prediction or high chances of having a pulmonary disorder. Again, it has a problem. This article I tumbled upon when I was going through false positive BDGs. It can be false positive in several cases, including use of IVIG, as I said, and even there can be, there can be other conditions like burns, CKD, cystic fibrosis, CMV infection, enterococcal infection, which can lead to a false positive BDG. So again, remember that host, correct setting, that has to be kept in mind when you are trying to get a hold of this disease. There are, again, a lot of PCRs available, which, again, if you're using a well-validated PCR test, it is a good test. It can be utilized for diagnosis of these ailments. Remember that the sensitivity and specificity, and actually even for that matter, the chances of picking up these diseases is poorer when you are giving your microbiologist a paraffin-embedded block. The chances of you picking up this disease will be higher when you are going to use a tissue directly or a sample directly. So try not to put these samples in formalin always. Always collect 2 samples when we are doing BAL. I'm sure most of the pulmonologists do that. This is only for students who are learning it. So they should always be 2 samples. Not everything that you take from the tissue when you are doing your TBLBs or other EBUSs and taking a biopsy, they should not only go in HPE, in formalin, or they should not, everything should not be fixed in paraffin. They should be a sample in saline, which can help you predicting these PCRs. They have very good sensitivity, by the way. But again, they do not differentiate. The problem with them is that they do not differentiate between colonization. So where do our good old cultures and what happens to our histopathology in such cases? So the thing is, the histopathology still remains gold standard. If you're seeing a fungal hyphae, acute angle branching, etc., that becomes a very, very categorical diagnostic, marker if you have that. But again, this takes time, right? You don't sometimes, if a patient is very sick, you don't have to, you don't have to do things like waiting for these histopathology. You don't probably have that kind of time. Hence, it is better if you have a diagnosis well within a day's time. So PCRs, your molecular diagnostics, everything, even CT scans, they help in early prediction of the disease, if not for the early probable diagnosis. Coming to treatment of invasive aspergillosis, this is something I picked up from ICMR. We know that most of the fungi, mold specifically, when I'm talking about aspergillosis, most of them are fairly sensitive to your all available drugs. They should be used. Voriconazole remains the drug of choice as per all the guidelines across Australian, Indian, American, all the groups endorse it. And something that has come recently into the system, that is a sevaconazole, that has been proven to be non-inferior to voriconazole. So both can be utilized or used. The sevaconazole has fairly good sensitivity. It can be used with lesser interaction and lesser amount of adverse events. The problem with the sevaconazole is cost. So it is quite costly, but it is safer in terms of sensitivity, specificity, and this trial, which was a RCT non-inferiority trial by name Secure trial, it proved that it works equally well when compared to voriconazole. So work-wise, it is doing same work. It is not lesser toxic, but probably cost should be the hindering agent when it comes to utility. Coming to second fungus, pulmonary muca. I have covered a lot of signs in the previous part of this thing itself. Pulmonary muca, the thing is, the mucormycosis usually occurs when your phagocytic functions or neutrophil functions is grossly impaired. So again, neutropenia becomes a very important risk factor for these patients as well. People who have, who are having iron overload, people who are CKD, CLD, they are at higher risk of developing mucormycosis, and these things can lead to dissemination of disease. Once a person has a disseminated mucormycosis, it can actually cause a high mortality. So the problem with mucor diagnosis is it is usually not picked up early. We all have to have a very high index of suspicion, clinically, lab workup, scans, everything in place, then only we will be able to pick up. The recent risk factor for mucor has been identified to be COVID also. We had a lot of COVID patients presenting with mucor recently. Since it is a pulmonology lung matrix that we are talking about, pulmonary mucus usually present with non-productive cough, sometimes hemopsis. And a CT scan usually shows multiple nodules, and a reverse halo sign is quite diagnostic of this particular fungal infection. So the olden European guidelines said that liposomal amphotericin B is the drug of choice for this fungi. Usually the dose is 5 milligrams per kilogram body weight, but for anything that is going into the brain, it should be used at a higher dose, that is around 10 milligrams per kilogram body weight, then only it will work. And the treatment depends on clinical recovery, so the treatment should not be halted after 2 days, 3 days. Say. The treatment for osteomyelitis, any bony involvement should go on for minimum of 4 to 6 weeks, followed by their continuation therapy. Treatment for lung mucus should at least go 4 to 6 weeks, and then it should be decided on patient's clinical recovery. So, yeah, once you have done that, you can actually come down to the continuation therapy, which can be one of the drugs that you use for continuation therapy is posaconazole, which is very commonly used. And one of the drugs that is used now recently is isavuconazole. Again, we have enough data to say that it is as equal or as good as, if not equal, as good as amphotericin in a limited disease. So if you have a limited sinusitis, say, with mucormycosis, you may get away by using just isavuconazole and prevent the nephrotoxicity, which is associated with amphotericin B. So we always, whenever mucormycosis comes, be it ROCM, be it lung, we always talk about surgical resection, surgical resection. So see how much effective these surgical resections are in Indian setup. We have this one study which was published from Medanta, had 44 patients, out of which 33 underwent surgery, 11 did not, because of the simple reason that they had too disseminated a disease for them to actually resect it. But they found that actually surgical resection proved to be beneficial, and the mortality was not, more post-surgically also. Hence, definitely try and surgically remove the affected part of lung in a mucor case. Resection with clear margins should be offered to all patients with COVID-associated pulmonary mucormycosis were operated in there. So here they said that aggressive management surgically actually helps in patients' prognosis. Again, this is a study which compared isavuconazole and amphotericin B and found out that isavuconazole can be used as an alternative when amphotericin B cannot be utilized due to any reason, be it toxicity, be it cost. In such patients, it is well tolerated, and it actually can be one of the alternative. So treating mucor, what is important? One is timely diagnosis. You miss the diagnosis or you wait for a little longer, patient will be dead. Reversal of underlying predisposing factors, that could be your diabetes, it could be your COVID, whatever it is, try treating them. Early and maximum surgical debridement, and there is a mortality benefit which has been proven. This particular percentage is actually from ROCM, that is a rhinoorbital mucormycosis, not for the pulmonary, but we have seen in the previous study that was published in Medanta that actually it has it has fair enough mortality benefit even in pulmonary mucormycosis. Rapid initiation of effective high-dose systemic therapy is also something essential, and if we miss out on that, and you only surgically remove, what will happen even if one fungus spore is remaining in the system, that will again multiply and undo all that you have done for the patient as yet. So make sure that when you resect, after that, once you operate, after that also you further go ahead and treat them with good dose of the antifungal drugs. So that brings me to the last part of my thing. I hope I didn't take longer, but yeah. So you have to individualize and evaluate. Make sure that you're considering all the risk factors that a patient has before you initiate your treatment, and your treatment should also depend on the patient profile. You cannot give, voriconazole to a CLD patient because there are hepatotoxicity you have to keep in mind. So you have to think again, titrate your drug accordingly, or use it very judiciously after telling about the patient side effects and all. Always be careful when you're using these antifungals about the adverse effect, and secondly about the interactions. So these two things make a lot of difference because our patients are predominantly immunocompromised. They are cancer patients, they'll be on chemo. A lot of these drugs actually interact with azole group specifically, so be careful about that. Know your host. Knowing your host helps the best. It helps you in titrating the patient treatment. It helps you in modifying the treatment. It helps you in monitoring the treatment in all possible ways. Assess and reverse the underlying risk factor if possible, whenever possible. So if you are, again, as I said, diabetic patient, treat the diabetes. So yeah, that brings me to the end of my presentation. I'll be happy to take any questions which are there.
Thank you,
Thank
Dr.
you.
Neha, to the great presentation. So we'll have questions later. We have our chief guest here.
Sure, sure. Thank you so much.